Hi, good day. We are welcome to this topic in the series of lectures. The title of today's topic is Cervical Intraepithehal Neoplasia, also known as Cervical Cin, and also cervical cancer screening. My name is Professor Jennifer Kayode Olusegun. I work at Obafemi Awolowo University Teaching Hospital and the University in Ile-Ife, Osun State, Nigeria. The learning objective for this topic is that at the end of this lecture, you must understand the natural history of cervical cancer. You must know the risk factors for cervical cancer and the importance of screening for cervical cancer. You must know the different screening methods, advantages and disadvantages of each, different methods of treating cervical premalignant lesions, otherwise known as CIN, Cervical Intraepithehal Neoplasia. By way of introduction, globally, there are over 530 cases of cervical cancer every year globally, leading to the death of over 270,000 women. The vast majority of the new cases and deaths occur in developing countries. In these developing countries, it is a major reproductive health problem. Due to the premature death of many young women, this subsequently has major effects on the family and it's a huge economic loss to the family and to the nation. Etiology of cervical intraepithelial neoplasia. Epidemiological, clinical, and molecular studies have implicated that human papillomavirus, HPV, is responsible for almost all the cases of cervical cancer. HPV is one of the most common sexually transmitted organisms globally. Most infections, however, are transient in people that have competent immune system. It is the persistent infections of the HPV that leads to development of cervical cancer. Though there are several types of HPV, only about 13 types are responsible for several cases of cervical cancer. Though HPV is necessary for the development of cervical cancer, it is not the only factor. Other factors are also implicated in the development of cervical cancer. Cervical cancer usually develops from the transformation zone, also known as the TZ. This is a ring of tissue between the old and the new squamous-columnar junction that has undergone squamous metaplastic changes as a result of the hormonal changes of puberty and the first pregnancy. The transformed zone is not constant, but is constantly changing as a result of the hormonal milieu of the woman. There are 3 types of transformation zone. In type 1, the transformed zone is fully visible with the new squamous-columnar junction on the ectocervix. In type 2, the transformation zone is partially or totally endocervical, but the new squamous-columnar junction is visible usually at the distal millimeters of the endocervical canal. An endocervical speculum may be needed in order to see the type 2 transformation zone. In the type 3 transformation zone, it is partially or completely endocervical, with the new squamous-columnar junction not fully visible as a result of its extension into the endocervical canal or the tightness of the cervical canal. Cervical cancer, as said earlier on, develops from the transformation zone. If the transformation zone is not fully visible, then colposcopic assessment is said to be unsatisfactory or inadequate. When we look at the physiology and biology of transformation zone, in the young girl, the new squamous-columnar junction is the ectocervix. Due to hormonal changes of pregnancy or during puberty, there is increased estrogen production from the ovaries. This leads to enlargement of the uterus, the cervix, and the appearance of female secondary sexual characteristics. As a result of this, the endocervical canal, which is lined by columnar epithelium, inverts onto the ectocervix. At the same time, the increased estrogen from the ovaries leads to deposition of glycogen in the vagina. The glycogen will be acted upon by lactobacillus and will convert it into lactic acid. The columnar epithelium of the cervix that has inverted into the vagina will come into contact with the lactic acid produced as a result of lactobacillus. This columnar epithelium cannot withstand the acidic changes of the vagina, so it becomes replaced by a new epithelium that can withstand the acidic environment. This leads to the formation of a new squamous-columnar junction. Now, the tissue between this new two columnar junction and the old one is called the transformation zone. That's where majority of cervical cancer develops from. Now, in terms of progression, cervical cancer is a slowly progressing cancer which arises from the pre-malignant condition called cervical intraepithelial neoplasia. This term CIN was introduced in 1960 by Richard. It is a concept that CIN or cervical cancer is a single continuous disease by which normal epithelium evolves into epithelial precursors lesions and onto invasive cancer. CIN is a histological diagnosis. CIN is conveniently divided arbitrarily, though, into three, depending on the degree of involvement of the cervical epithelium by the abnormal cells. This division is artificial. Different lesions may be found on the same cervix. In CIN1, which is also known as mild dysplasia, we have CIN2, moderate dysplasia, and in CIN3, severe dysplasia or carcinoma in situ. In CIN1, there's a good maturation with minimal nuclear abnormalities. Undifferentiated cells or the abnormal cells are confined to the lower third of the epithelium. There are few mitotic figures. In CIN2, the dysplastic cells are restricted to the lower two thirds of the epithelium. In CIN3, the differentiation and stratification may be totally absent, and the abnormal cells are present in all the layers of the epithelium. In CIN3, there are numerous mitotic figures. The nuclear abnormality extends throughout the thickness of the epithelium. All these changes, CIN1, 2, and 3, are reversible, but the ease of reversal decreases from CIN1 to CIN3. CIN2 and 3 are considered high-grade lesions and form the threshold for treatment of CIN1 in many countries. CIN3 is considered a true malignant precursor. This is the diagram. We have CIN1, CIN2, CIN3. Up to CIN3, all those abnormalities are reversible. But when the abnormal cells breaches the basement membrane, it forms invasive cancer. At that point, it is no longer reversible. The next slide will show us the regression, persistent, and progression of CIN1. In CIN1, it has a regression rate on average of about 57%, persistence of about 32%, and progression to CIN3, 11%, progression to invasive cancer, only 1%. So there is no need to treat a woman that has CIN1 because it has a very low probability of developing invasive lesion. CIN2, the regression is 43%, persistence 35%, and progression to CIN3 is 22%. It has 1.5% risk of progression to invasive cancer. Whereas CIN3, the regression rate is 32, less than 1 and 2. The persistence rate is 56, and has a risk of progression to invasive cancer of about 12%. Though in many countries, CIN2 and CIN3 are considered high-risk lesions, whereas based on this slide, CIN3 is actually a true malignant precursor. Now, what are the other risk factors apart from the acquisition of HPV? We have the host factors such as sexual and reproductive history, that is early age of sexual intercourse, having multiple sexual partners, multiparity, and prolonged use of combined hormonal contraceptive pills. The host immunity also play a role in the development of cervical cancer. In people that are immunocompromised, that those people with HIV/AIDS, those on chronic steroid therapy, those with transplants, have reduced clearance of HPV. In these immunocompromised individuals, the CIN and the HPV tends to persist more than people that have competent immune system. The HPV type is also important in development of cervical cancer. Earlier on, I said there are about 13 high-risk human papillomavirus, of which type 16 and 18 are responsible for about 70% of cervical cancer globally. So all the HPV types don't carry the same risk of causing cervical cancer. 16 and 18 are the most important globally. Now, how do you know a woman has CIN? What are the clinical features of cervical intraepithelial neoplasia? Generally, CIN has no specific symptoms, and there are no characteristic clinical features that can make somebody to determine who has CIN or not. This is one of the reasons why cervical cancer is difficult to prevent, because CIN is a pre-malignant condition but does not give any symptoms. So it's very difficult in any developing country to convince women to come for screening when they don't have any symptoms. CIN is diagnosed when the woman has an abnormal screening test and she is referred to colposcopy. During colposcopy, which is magnified visualization of the cervix, certain features may be recognized, such as abnormal vascular pattern, acetoacetate reaction when dilute acetic acid is applied to the cervix, or the cervix may be iodonegative when glucose iodine is applied. After an abnormal screening test, colposcopy is usually done to confirm or exclude invasive disease and to take targeted therapy. Histopathological examination of the tissue that is taken during colposcopy will reveal the presence or absence of cervical intraepithelial neoplasia. How do you screen cervical cancer? Now, of all the gynecological malignancies, cervical cancer is one that is amenable to prevention. This is because it has a well-defined pre-malignant phase, which is CIN1, from CIN1 to CIN2 to CIN3 to invasive cancer. So these have been well-defined. This gives us the opportunity to do what? To intervene at any of these steps to prevent the development of invasive lesion. Screening and treatment of pre-malignant lesions has the potential to prevent most cases of cervical cancer. In Europe and North America, cervical cancer screening has drastically reduced the incidence and mortality from the disease. Developed countries bear the greatest burden of cervical cancer due to lack of screening. Lack of screening is the greatest risk factor for development of cervical cancer. Screening aims to detect the pre-malignant phase, that is CIN1, 2, and 3, and if not treated, may progress to cervical cancer. For cervical cancer to be effective, there must be coverage of at least 80% of the women at risk. This screening program must be well organized and should be population-based rather than opportunistic. There should be adequate treatment of dictated lesions. There is no point screening a woman if there are no provision to treat her. There should also be adequate follow-up of cases. Now, what are the methods of screening for cervical cancer? The pap smear, that is the earliest screening method for cervical cancer. It is still the main form of screening for cervical cancer in many countries. It involves scraping the abnormal cells from the cervix. This is put onto a glass slide. The cells are fixed, stained with special dyes, and read under the microscope by cytopathologists. If abnormal cells are found, then the woman is referred to colposcopy. This diagram shows a pap smear being collected, and there's a glass slide beside in which what is obtained from the ectocervix is smeared onto the glass slide. Pap smear is relatively painless procedure. It has moderate sensitivity. Due to this, women are encouraged to do pap smear screening every 3 years. It has good specificity. Different countries have different starting ages for pap smear. Pap smear is a laboratory screening method and required highly trained personnel. Many developed countries lack the personnel and infrastructure needed to implement a successful pap smear screening program. In addition, pap smear requires multiple visits before treatment can be administered. The first one is that you need to do the smear. After the smear, the woman will have to come back for the results. If abnormal results are found, the woman is referred to colposcopy. At colposcopy, targeted tissue are obtained. Biopsy is taken from the abnormal area. This is also sent for what? For histopathological examination. So all these take multiple visits. As a result of this, there's a very high loss to follow-up rate in many developed countries. That is one of the reasons why many countries cannot implement a successful, high-quality pap smear screening. Due to inability of many developing countries to implement the cytology-based screening program, which is the pap smear, one of the alternatives recommended for screening is the visual inspection technique. One of them is visual inspection with acetic acid. In this method, it involves painting the cervix with dilute 3 to 5% acetic acid, also known as vinegar. Then you wait for 1 minute to observe color changes on the cervix. It is based on the principle that abnormal cells of the cervix contains high amount of protein, nucleic acid, which you coagulate after application of acetic acid, gives a white appearance known as aceto-white appearance. It's a very cheap and sensitive method of screening for cervical cancer. All the materials needed for the performance of VIA can be sourced locally. It is not laboratory based. Most health workers can perform it. And you only wait for 1 minute to get result. So results are obtained immediately. Because the results are obtained immediately, it leads to reduced loss of follow-up. It, however, lacks specificity, as there are many benign conditions on the cervix that can give aceto-white reaction. Another screening method is visual inspection with Lugos iodine. It involves the application of Lugos iodine onto the cervix. Abnormal cells on the cervix lacks glycogen. So when iodine is applied on the cervix, it turns yellow due to the absence of glycogen. Normally, it's supposed to turn dark brown, but because there is no glycogen in abnormal cells, it turns yellow. So results are also obtained immediately, 1 minute after application of the Lugos iodine on the cervix. So the advantages of visual inspection techniques includes screening can be combined with immediate treatment. That is, the results are obtained within a minute, and the woman can be informed about the result, and she can be treated before she leaves the S facility. So this minimizes the loss of follow-up. This is also a method of combining screening and treatment in the same clinical setting. In one visit, it's also known as see and treat technique. This, as good as the visual inspection techniques are, they also have some advantages. You need to visualize the transformation zone before you can use the visual inspection technique. In postmenopausal women, the transformation zone cannot be visualized because it will have receded into the cervical canal due to the absence of estrogen in postmenopausal years. So it is also very subjective because it is a technique of pattern recognition. You need to be able to discern colors. So which one is aceto-white, which one is negative before you can be able to perform VIA. So it is very subjective. Being subjective, it is not reproducible. It has high intra and inter-observer variations because what I see to be aceto-white, other may say it is not white. What I see to be yellow, other may say no, it is not yellow. Due to this, it has intra and inter-observer variations. Because there are so many benign conditions on the cervix that can give aceto-white reaction, it has low specificity. That means the mere fact that there's aceto-white lesion on the cervix does not mean that the woman has cervical pre-malignant conditions. So if treatment is combined with screening in the same clinical setting, it may lead to over-treatment of women. Another screening method that is rapidly gaining ground round is the human papillomavirus testing. I said in my introduction that human papillomavirus is one of the most common sexual transmitted infections globally and is the etiological agent for cervical cancer. It's a molecular-based method, that is, it is producible, it is relatively more sensitive, it is more expensive and very sensitive. Yet, however, because HPV is most common sexually transmitted infection globally, it has moderate sensitivity. It, however, should not be used in adolescents because in young women, HPV screening should not be used because at the commencement of sexual intercourse, a lot of women will have human papillomavirus, which normally will disappear without any treatment. So if HPV screening is used in young women, a lot of women will be identified as being HPV positive, whereas they will be able to clear the infection on their own without the need of any therapy. Advantages of HPV screening includes if it is reproducible, it is very sensitive, and it can be self-collected. Because it can be self-collected, the woman can screen herself actually if taught how to do it. It is very important in certain settings due to religious and cultural values. Some women may not want to be screened by a male health worker, or some women may not want to be screened by health workers that are at the age of their own children. So HPV can be self-collected. It also has very high negative predictive value. Thus, screening interval can be lengthened, can be increased. For example, if a woman screened negative for human papillomavirus, screening shows she does not have HPV. Chances of that woman developing cervical cancer is very, very low. That is, it has very high negative predictive value, very low, risk of developing cervical cancer in a woman that's screened negative for HPV. It can also detect adenocarcinoma more than the other screening method. It can also be used as a reliable test of cure after treatment for premalignant lesions. If a woman is treated for CIN1 and HPV testing is performed on her and she is negative, that means she has been cured. Now, this is the slideshow colposcopy, which I said is done usually when a woman has abnormal screening test. It is from colposcopy that we take a tissue, which is called biopsy. Biopsy will be sent for histopathological analysis that will reveal CIN1. Now, what is the management of CIN1? It's not enough to screen a woman. We must also manage how she should be adequately managed. Because screening alone does not reduce the incidence of cervical cancer, but treatment of detected cases. How do you manage? Most cases of CIN1, or CIN rather, cervical intraepithelial neoplasia, is managed by outpatient procedure, which may be ablative or excisional. In effective management of CIN1 requires the destruction of the transformation zone, because that is where cervical cancer develops from. So if we are managing any woman with CIN1, we must ensure that the transformation zone is adequately destroyed. There are two main methods of management of CIN. It could either be ablative or excisional. In ablative method, we are destroying the abnormal cells in the transformation zone. We are destroying it right there on the cervix. The main disadvantage of this method is that no tissue is obtained for biopsy. There are so many ablative types. These include cryotherapy, thermal ablation, and laser vaporization. I'll quickly mention cryotherapy. Cryotherapy, also known as cold therapy, it involves freezing the abnormal area of the cervix, the TZ, with compressed gases, either nitrous oxide or carbon dioxide as the refrigerant. That means the gas is forced out through a small nozzle and causes freezing of the cervix when the probe is applied to the cervix. The refrigerant, either carbon dioxide or nitrous oxide, are forced through a small hole at high pressure rather. This produces a very low temperature of about minus 65 degrees to minus 65 degrees at the surface of the probe. At this temperature, there is intracellular and extracellular crystallization of water, which subsequently leads to cellular dehydration, increase in intracellular concentration of salt, and release of lysosomal enzymes and cellular destruction. Cryonecrosis of cell occurs at a temperature of minus 20 to minus 30 degrees centigrade. These are the components of cryotherapy. The cryo gun is there. There's a probe at the tip of cryo gun. Then there's a trigger. There's an handle, a grip. There's a yoke. Then it is connected to a gas cylinder. So the gas is forced through that probe. That's the tip. And that tip is placed on the cervix. Now, before you use cryotherapy, there are selection criteria that must be met. The criteria includes the lesion. The abnormality we are seeing should occupy less than 3 quadrants of the transformation zone. When you look at the face of the cervix like a clock, the abnormality we are trying to destroy must occupy less than 75% of the transformation zone. The abnormality must not extend into the endocervical canal, and there should be no extension of the abnormality onto the vaginal walls. The entire lesion should be covered by the cryoprobe, and the squamous junction must be visible throughout, and there should be no clinical or colposcopic suspicion of invasive cancer. That's the cryotherapy. The probe is applied on the cervix. Treatment may either be straight 5 minutes, that's single and freeze, or we can use double freeze and thaw. We freeze for 3 seconds, allow the cervix to thaw for another 5 minutes, then we now freeze for another 3 minutes. 3 minutes, allow the cervix to thaw, then another 3 minutes of freezing. We call that one double freezing. So this is how the cervix looks like after cryotherapy. There's an ice ball that is formed after treatment. That is the appearance of the cervix after cryotherapy. Now, advantages of cryotherapy, advantages are it is a very cheap method. It is easy to teach, does not require the use of electricity unlike clip. It is cheap, it is very effective if patients are carefully selected. The advantages of cryotherapy is that it involves the use of gas, which may be difficult to obtain in many developing countries and cannot be used to treat large lesions. Like I said, if the lesion occupies more than 3/4 of the cervix, if it is not amenable for treatment with cryotherapy. And also because we don't obtain tissue before we treat, we cannot confirm our diagnosis and cannot be used for postmenopausal women with lesions because we cannot see the subocolumnar junction and the assumption zone is not fully visible. Due to the advantages of the cryotherapy, difficulty in getting gas, and that cryotherapy involves very large cylinder, which is very, very difficult to transport from one treatment center to the other. Another method of therapy that is being used is called thermoablation. It's also called cold coagulation or thermocoagulation. It is a very lightweight portable machine. It has a metallic probe, which is heated by either electric current or a battery to a temperature of about 100 degrees centigrade. The heated probe is applied to the cervix for about 30 to 45 seconds. It leads to epithelial and stromal destruction of the transformation zone. It has the same indication and contraindications as cryotherapy, though treatment time is shorter with thermoablation because the least time with cryotherapy is about 5 minutes and the maximum time is about 11 to 12 minutes. But with thermoablation, treatment time is short, about 25 to 35 seconds. Now, thermoablation has the advantage that it does not require compressed gas, which is difficult to obtain in many low, middle-income countries. It's very lightweight and portable. It can be used by a wide variety of health workers. The earlier method of thermoablation devices uses electricity, but currently a power bank or battery can be used to charge the thermoablation, so we don't need to use electricity for it. Side effects of ablative therapy generally, be it thermoablation or cryotherapy, is that the woman may experience lower abdominal cramps during treatment. This is due to release of prostaglandins following cellular destruction. The lower abdominal cramps may be relieved by administration of non-steroidal anti-inflammatory analgesic, provided the woman is not a peptic ulcer patient. Vaginal discharge is another major side effects of ablative therapy. This usually follows the use of, this watery discharge usually lasts for about 10 days to 2 weeks. Other ablative methods include laser, which can be used to destroy the abdominal epithelium. Laser equipment are very expensive and difficult to maintain in resource-poor country. Electrocautery can also be used to destroy the abdominal cells. Occasionally, there may be bleeding from the tissue after ablative therapy. The other major treatment of CIN is excisional method. In this method of treatment, the abdominal area of the cervix is completely removed. Unlike the ablative therapy, in excisional therapy, we are cutting away the transformation zone. The advantage of this cutting away is that the tissue we remove can be sent for histopathological examination. The main excisional method is loop electrosurgical excision procedure, LEEP, or also known as LES. It involves the use of thin stainless steel or tungsten wire heated to high temperature to excise the area of the transformation zone. The main advantage is that the tissue specimens are available after the procedure for histopathological examination. It can also be used to abnormal a large area of the cervix, irrespective of the size. Even the ones that extend to the canal or occupies the whole of the exocervix can be used to excise. The lip can be used to excise the abnormal area of the cervix. That example of lip, that's a very thin wire heated to very high temperature, and it is used to cut the abnormal area of the cervix, which is the transformation zone. Other excisional method is cone knife cone biopsy. It is the traditional method of excising abnormal areas from the cervix. Cone biopsy may either be diagnostic or therapeutic. The disadvantages of cone knife biopsy is that it is done in the operating room, requires the use of regional or general anesthesia, making it more expensive with significant morbidity, and cone knife colonization has adverse obstetric outcome. If the cone is large, involves the internal os, it may lead to cervical incompetence, premature rupture of fetal membrane, preterm delivery, low birth weight baby, or cervical incompetence. In addition, it also requires good surgical skills. In conclusion, cervical cancer is a preventable disease if screening is instituted. Lack of screening is the greatest risk factor of cervical cancer, and that is why many developed countries have very high incidences and mortality. There are many screening methods of cervical cancer, each with its own merits and demerits. Screening must be accompanied by adequate treatment of detected cases. P. marginal lesions are generally managed by outpatient methods. Thank you for listening.